So now it's my pleasure to introduce Dr. Jennifer Yeh, who is a decision scientist whose research focuses on improving health outcomes at the population level. She is an assistant professor of pediatrics at Harvard Medical School and Boston Children's Hospital. She has a master's in health policy and management from the Harvard T.H. Chan School of Public Health and a PhD in health policy from Harvard University. Her research focuses on applying methods of decision science, simulation modeling, and economic evaluation to identify opportunities to enhance cancer screening and surveillance programs. Her presentation will review her research evaluating the cost effectiveness of routine echocardiography screening for asymptomatic left ventricular dysfunction.
Thank you, Melissa. Let me start my slides. Let's see. Okay. Well, thank you to Melissa for that nice introduction, and thank you to Sophia's Hope for hosting this webinar today. So today I want to share with you a study that uses decision modeling to estimate the clinical benefits and cost effectiveness of echocardiography screening for asymptomatic left ventricular dysfunction among survivors of childhood and adolescent cancer. I'll start by providing some motivation for the study, as well as then moving on to our model-based approach, and then share with you our findings and the implications. So let's start with the motivation. So in 2003, as many on this call today are familiar with, the Institute of Medicine issued a report on childhood cancer survivorship, which outlined a comprehensive policy agenda to improve long-term health for survivors. It was really the first to describe the need for risk-based care and evidence-based guidelines for childhood cancer survivors. And since then, several clinical practice guidelines have been published for many of the late effects that survivors face as adults. But often they include differences in at-risk populations and recommendations, which may hinder their implementation. Recognizing the benefits of collaborating, the International Late Effects of Childhood Cancer Guideline Harmonization Group, IGHG, was established. One of the first conditions that the IGHG focused on was anthracycline-related cardiomyopathy. So the IGH reviewed and graded existing evidence and formulated recommendations for cardiomyopathy risk stratification, screening, and follow-up care, which are summarized here. For the high-risk subgroup, who was defined based on cumulative anthracycline and/or chest radiation dose, the IGHG recommended and found they had a strong recommendation citing high-quality evidence to recommend routine screening for this high-risk subgroup and suggested an interval of screening every 5 years, though citing that there was moderate quality evidence suggesting that more frequent screening could be warranted. For the moderate and low-risk subgroups shown here, the IGHG found that there was some evidence that screening could be warranted for these individuals, and if so, screening at every 5 years may be appropriate. So while these consensus-based recommendations provide guidance for follow-up care for survivors, their benefits and harms and costs of screening remain uncertain. And this may explain in part why adherence rates to screening recommendations are currently low. A recent study published based on the data from the CCSS found that less than 50% of survivors adhere to the recommendations. This suggests that we need additional data that can strengthen the evidence base for screening recommendations, and then can really facilitate the discussions between clinicians and survivors as they discuss the potential benefit of undergoing routine surveillance. So while we often think of randomized clinical trials as the gold standard, they aren't always feasible for screening studies, in particular among survivors of childhood cancer, given the number of survivors and the time horizon that would be required. Observational studies provide real-world data, but they often are incomplete in the clinical and policy outcomes that are needed to inform screening guidelines. Decision modeling provides a complementary analytical approach that can uniquely address these challenges. And decision models are increasingly being used to inform clinical practice guidelines. For example, in the US Preventive Services Task Force has used decision models to establish cancer screening guidelines for average risk individuals in the population. So what is decision modeling? So decision modeling is a formal methodological approach for simulating the effects of different interventions on health and policy outcomes. It entails structuring components of a process or decision over time using mathematical equations. And these processes can include the clinical history, the natural history, or the clinical course of a disease, as well as prevention and treatment. It synthesizes data from multiple sources in order to parameterize the model. And these data sources can include RCTs, clinical studies, observational studies, as well as expert opinion. And then it projects and allows comparisons of outcomes across various strategies of interest. And these outcomes can include life expectancy, lifetime risks, and lifetime costs. And when we talk about costs, we often conduct what is called a cost-effectiveness analysis. So CEAs provide a way to evaluate both the costs and health outcomes associated with 2 or more interventions. So the goal of CEAs is really to determine whether the value of an intervention justifies its cost. CEAs are designed to allow decision makers to clearly understand the trade-offs between the cost and the health outcomes among different strategies. And it combines these considerations into a single metric called the incremental cost-effectiveness ratio, or ICER, that can be used to inform decision-making when limited resources are available. It's important to note, once my slide catches up, oops, there we go, that CEAs do not make the decision for individuals, clinicians, or policymakers about what the preferred strategy may be, but rather it provides information that can facilitate decision-making. And therefore, we should think of CEAs as one tool that can aid in our decision-making process. So now moving on to our study. So the objective of our study was to estimate the clinical benefits, harms, and cost-effectiveness of various screening strategies for the IGHG-defined cardiomyopathy risk groups. So specifically, what are the clinical benefits associated with routine screening? What are the harm-benefit trade-offs? And is cardiomyopathy screening considered a good value for the resources invested? We developed a microsimulation model of the clinical course of asymptomatic left ventricular dysfunction and heart failure. And the data sources we used to develop this model included data from the Childhood Cancer Survivor Study, the St. Jude Lifetime Cohort Study, published literature, and databases. Shown here are the model outcomes that we focused on, including the benefits, including the reduction in heart failure risk, as well as the improvement or gain in life years or quality adjusted life years. The harms in terms of the average number of screens a survivor would undergo over the course of their lifetime for each strategy evaluated, costs, and the incremental cost-effectiveness ratios, which we express as a cost per quality adjusted life year gained. So shown here are the health states included in the microsimulation model of the clinical course of ALVD. And let me walk you through what happens in the simulation. Having a little bit of a lag here. Okay. At the start of the simulation, 5-year survivors enter the model with either no ALVD or ALVD. In our case, it was just a small proportion that had ALVD already. Each month, survivors face a risk of progressing to ALVD or heart failure. In the model, heart failure risk comprised of 2 components, treatment-related risk as well as age-related risks. So the treatment-related risk was based on a statistical model that was fit to CCSS data that included age at cancer diagnosis, cumulative anthracycline dose, and cumulative heart radiation dose. And then for the age-related risks, acknowledging that as these survivors age and enter into adulthood, they face age-related risks, much like many of us do on this call. And these risks were based on data from the Framingham Heart Study. The risk of progression from ALVD to heart failure was then estimated using data on asymptomatic and symptomatic cardiomyopathy from St. Jude Life, which really leveraged their direct assessment study design. Survivors who develop heart failure are at risk from dying from the disease. And all survivors are at risk of dying from other excess late mortality risks, as well as background mortality risks. And all individuals are followed throughout their lifetime. We used model calibration to data from the CCSS to ensure that our model outcomes were consistent with observed data. So now that we have this model, which allows us to simulate the clinical course of ALVD, what we can do is then overlay a screening module that allows us to simulate the outcomes associated with routine screening. So in our study, we evaluated no screening, which was our baseline strategy, and then interval-based screening every 10, 5, 2, and 1 years. In our model, individuals that were screened that had a positive echocardiogram were assumed to receive ACE inhibitor and beta blocker treatment per guideline-based care. And using data from the SOLVE prevention trial, we assumed that treatment reduced the progression to heart failure as well as mortality from cardiac causes, as shown here. So other model parameters, such as screening performance, costs, and quality of life weights, were based on published studies and cost databases. So shown here, we can see that in our study, for the sensitivity and specificity of echocardiogram, we assumed the sensitivity of 50% and a specificity of 92%. The costs associated with both screening and treatment were based on Medicare reimbursement rates. And then so that we could estimate quality adjusted life expectancy, we incorporated age and specific utility weights for survivors, as well as accounted for the disutility associated with taking daily medication for those that had a positive echo screen. In addition to more fully capture uncertainty, we conducted 1,000 simulations, sampling from the underlying distribution from each model parameter for each simulation to allow us to report both the mean and 95% confidence or uncertainty interval for all modeled outcomes. So what did we find? Among a cohort representative of the CCSS participants, the projected lifetime risk of heart failure ranged from 17% in the low risk subgroup to 37% for the high risk group, as shown here. And I think this figure nicely shows that the IGHG criteria stratify survivors into 3 distinct risk categories. Routine echocardiography screening reduced the lifetime heart failure risk from 4% with 10-year screening intervals and up to 11% with 1-year screening intervals. These results suggest that screening with echocardiography can prevent up to approximately 1 in every 10 heart failure cases. In terms of the harm benefit trade-offs, the model projected the number of screens per heart failure case averted. So we can think of this number similar to the number needed to screen or the number needed to treat that is often reported for screening or treatment studies. Except in this case, we are looking at the total number of screens for a cohort of survivors compared to the number of cases averted among the same cohort of survivors. So for the high-risk subgroup, the number of screens per heart failure case averted varied by screening interval, and it ranged from about 380 to just over 1,000. For the low-risk subgroup, the number of screens was more than 1,000 for all strategies. And for the moderate risk group, the number of screens per heart failure case averted ranged between 650 to almost about 1,700. And these results tell us that the harm benefit trade-offs were more favorable or lower for the less frequent screening strategies, as well as among the higher risk subgroup. So what about the cost effectiveness of screening? So shown here are the CEA results for the high risk subgroup. And we need some sort of benchmark that can help us interpret the meaning of these estimates. So in the US, it's generally considered that interventions that have an incremental cost effectiveness ratio, or ICER, of less than $100,000 per quality gain are considered good value for resources invested. In using this threshold, we can see that screening every 10, 5, or 2 years were all considered cost effective for the high risk subgroup, with 2-year screening yielding the greatest gain in QALYs, and therefore was the preferred strategy. And as I mentioned, we conducted the simulation 1,000 times, which allows us to estimate the probability that a specific strategy would be the preferred strategy among the 1,000 simulations. And when we look at the individual simulations, we see that screening every 2 years was most likely to be the preferred strategy. In contrast, for the low-risk subgroup, the ICERs for all interval-based screening strategies exceeded the $100,000 per quality gain threshold, and none were considered to be cost-effective. So you can see here, the ICERs actually were quite high, ranging from $180,000 for screening every 10 years up to $750,000 for screening every 2 years per quality gain. And no screening was the preferred strategy among the vast majority of the 1,000 simulations, which really provides more confidence in our findings. For the moderate risk group, the ICERs for screening every 10 and 5 years were both below the $100,000 per quality gain threshold. But there was considerable uncertainty in which strategy was preferred among the 1,000 simulations. And we can see that here that the strategies of no screening and 5 years had about the equal likelihood of being the preferred strategy. What's really nice about the simulation model is that in addition to estimating our estimates for the base case, we can also vary model parameters to understand how changes in model parameters are influencing the model outcomes. And we did this in sensitivity analyses for a wide range of model parameters. And we found that the strategy remained largely unchanged, or the preferred strategy remained largely unchanged for both the high and low risk subgroup. So for example, shown here are the results of a one-way sensitivity analysis on sensitivity of echocardiography screening. So when we varied the sensitivity from 20 to 70%, we can see here that the preferred strategy remained the same across this plausible range. So for the high risk subgroup, the preferred strategy, given a $100,000 per quality gained threshold, was screening every 2 years. And for the low risk subgroup, no screening remained to be the preferred strategy. In contrast, findings were less robust for the moderate risk group. And you can see here that across the same plausible range for echo sensitivity, we see that the preferred strategy shifted from screening every 5 years, shown in green, to screening every 10 years, shown in red, to no screening, shown in blue. This really underscores the uncertainty for this subgroup, as well as the need for additional data. So our study had several limitations. The most important, in my opinion, is the treatment effectiveness associated that was used to inform the benefit of ACE and beta blocker inhibitors. We based this data on data from the SOLVE trial, as there were no studies available on survivors of childhood cancer. Importantly, the SOLVE trial, it focuses on older adults who have heart failure that's unrelated to cardiotoxic therapies. However, in conducting sensitivity analyses, we found that our results were very robust to this assumption. There are other risk factors that may influence heart failure risk, including the cardiovascular risk factors that Eric had mentioned. And there may also be patient preferences that will be important for clinicians and survivors to consider as they make individual level decisions about screening. We reported the number of screens per heart failure case averted, but we don't really have a benchmark that allows us to gauge what the appropriate trade-off may be. Of note, if we looked at the results for the harm-benefit trade-offs next to the cost-effectiveness analyses, we see that the strategies that had high benefit harm ratios of over 1,000 screens per heart failure case averted were the same strategies that had incremental cost-effectiveness ratios that were exceeded the $100,000 per quality-adjusted life years. We also base costs on Medicare reimbursement rates, which may underestimate rates for younger survivors. And our CEA results may not be generalizable to settings outside of the US, since we did use US costs, as well as a US-based threshold for what is considered to be good value for resources invested. A real strength of the model-based approach, however, is that as new data become available, the model can be refined to provide updated estimates. So in summary, our findings provide support for the cardiomyopathy screening among survivors and suggest that refinement of IGHG recommendations warrants consideration. For the high-risk subgroup, screening more frequently every 2 versus 5 years can reduce heart failure and is cost-effective and should be considered. For the low-risk subgroup, routine screening may reduce heart failure risk, but because of their lower absolute risk, screening does not appear to be cost-effective. Updating guidelines to omit screening for this subgroup should be carefully considered. we note that additional data is needed before refinement of screening guidelines for the moderate risk group can be made. I hope that this study also demonstrates how decision modeling can inform and improve follow-up guidelines for survivors. I want to acknowledge our study team and our collaborators for the study, as well as our funding. In particular, I want to acknowledge Matt Earnhardt at St. Jude, who led the study and just did a wonderful job in writing it up. It was published in JCO last year, as shown here, as well as to the CCSS and St. Jude Life studies, who were so generous in sharing their data with us for this study. And I will end here.